So 3D echo, I have no disclosures in the OR, in the hybrid OR or in the Cath Lab. TAVIs was a little bit covered by Jörg Ender. I will show you some slides. I will mainly focus on the mitral clip. ASD closures was covered by Stefan Rex, and the LAA closure, I will show you 2-3 slides on that. Who is involved in hybrid or Cath Lab echo? Some. And you use the 3D? Yes. Not so much. Maybe I can convince you. As you know, with the TAVI, there are a lot of valves there and a lot of excess. And unfortunately for the echocardiographer, at least for the transfemoral excess, a lot of procedures are done under conscious sedation, so we don't use echo in conscious sedation patient anymore. But what is crucial is sizing. And in contrast to conventional aortic valve replacement, the interventionalist cannot place a sizer in the aortic annulus and to get the correct size. So it all depends on imaging. That is a major difference between conventional AVR and TAVI. And we know that 2D, especially also transthoracic, due to the visualization of the aortic annulus, severely underestimate the aortic annulus. So that is really one major advantage of 3D echo, that you can compensate on that. Usually CT scan is a method of choice because CT has one additional advantage. Calcification is not a problem with CT, whereas calcification is a problem in echo, as you know that, because the ultrasound beams doesn't penetrate the calcification. But with 3D, you get the first time the possibility to really planimetry and do the dimension of the left ventricular outflow tract just below the aortic annulus. And that is how the sizing is done. Jörg Ender has mentioned that using X-plane is a possibility. Yes, it is. But remember that you have a risk of non-coaxiality. So that means if this would be your plane, the red one, then it's the same with that short axis I have shown you, transgastric. You will measure not the correct diameter. So you have to be sure that you measure in that plane, the left ventricular outflow tract. Okay, so you have to adjust your 2D image, if you use X-plane, that you have your aortic annulus horizontal, and then you can use the X-plane. The other most appropriate method used is you use really the 3D and the MPR. So this is from the EACTA paper where they recommend the 3D use in TAVIs. So you start from the long axis. And then if you look at that short axis, you have 2 long axis planes available. Then you rotate it and you have that short axis which is displayed here. Here the short axis is at the aortic sinus. And if you move that plane below the aortic annulus, then you can really adjust the left ventricular outflow tract. Then you have to be sure that it's really a good coaxial long axis view in both views, and then you end up with the left ventricular outflow tract, as you see it here, right below the calcification of the cusp in each of the long axis views. And then you can measure these 2 dimensions. And we know that also from the CT, that the LVOT is not a round structure. It's not circular. It's ellipsoid. And you can demonstrate that as well in 3D echo without radiation and everything. The other thing which was mentioned from Jörg Ender as well is that you can measure the distance from the annulus to the left coronary artery with 3D, which is not possible in 2D. And again, you have to use that multiplanar reconstruction mode where you can have the left coronary artery here and you can measure it in the long axis, the distance, which is also crucial. So this is the main advantage for the TAVIs, the measurement. So interprocedural, you know that it's more or less depending on